So thank you, Nate. Hi, my name is Maia Dorsett, as Nate just said, and I serve as the medical director for EMS education at our community college paramedic program. I'm really excited to share with you today how we've used team-based learning as an instructional format to discuss EKG differential diagnosis within our paramedic program. Before I dive into the meat of this webinar, though, I want to start with sort of one assertion that also describes my motivation for my involvement in EMS education, which is that I think that paramedic education is one of the greatest challenges that we have in medical education. And the reason is this, which is at the end of this road, which is relatively short, we are trying to build clinicians who can use critical thinking to effectively respond to and treat undifferentiated patient populations. And as I said earlier, compared to other clinical tracks, this is actually a relatively short period of time to teach this higher order thinking and clinical management. And our job as EMS educators would be a lot easier, right, if patients fit into nice, clean diagnostic boxes. So you guys lost me here. So I'm just gonna sort of go back a little bit through and say, so as I said earlier, right, our job would be a lot easier if patients fit into sort of nice clinical packages, but the world of medicine is a lot more gray, and that there's a lot more overlap between those different patient presentations. And so part of our job, right, is to teach our students and the future clinicians to operate within this gray zone of medicine and take the knowledge that they've learned, right, and combine that with data through patient assessment, other adjuncts, including EKGs, and then apply that to give their patients the best possible treatment. So as far as instructional formats that a lot of us are familiar with, to do that, simulation and case-based learning are really common instructional formats that we use. But those formats are really intensive, not just in terms of resources, but in terms of instructors, because the instructor to student ratio is relatively low for both of those. And so one of additional instructional format that you can use that really focuses on knowledge application is something called team-based learning. And so really, what is team-based learning? It's a structured small group activity that emphasizes student preparation outside of class and then application of that knowledge within class in a collaborative learning strategy. And I first became familiar with this not as an educator or instructor, but as a learner, initially in medical school and then subsequently in my residency training at WashU, where we would use this on an almost monthly basis in the context of residency education. And while today I'm going to be talking about how I've applied it to teach EKG differential diagnosis, I think it's worth talking a little bit about how you set up team-based learning because I think it's much more widely applicable, and I do use it to teach other subjects within the paramedic program. What team-based learning does is it takes the emphasis away from this, which is the instructor as a dispenser of information, and rather puts the emphasis on the students who need to sort of actively engage in activities that require them to use concepts to solve problems. And while it was developed really for in-person classroom teaching, and I recognize that most of the classrooms, including mine, look more like this right now, I think a lot of the same principles can be used to design virtual learning through the combination of things like breakout rooms within Zoom or additional polling software. So the structure of team-based learning has three parts. So the first part is the preparation, the pre-class. This is asynchronous work that is assigned ahead of time. That really the goal is to lay the knowledge foundation for the concepts that you're going to be applying in class. Then there's an accountability, which is a huge part of team-based learning for doing this preparation, because the first synchronous portion of it is a readiness assurance component, which has both an individual and then a group component. And then finally, once that baseline knowledge is sort of reviewed and solidified, then they do a series of modules which are really about application of course concepts. And mentally, I really sort of think of this as, well, it is 3 parts. It's really 2 parts, right? The last part is focus on what do I want them to be able to do, which is the end focus of the entire exercise. And so when I think about designing preparation and readiness assurance activities, it's really thinking about what do they need to know to be able to do it. So if I think about doing this for EKG education, right, what I really care about, right, is that my students end up being able to combine their patient assessment, their clinical situation, with adjuncts such as an EKG to decide on patient treatment. And so when I think about what am I going to assign for, what do they need to know ahead of time, right? It's not just pre-work on EKG interpretation, which we do separately in sort of a more traditional format, but it's additional resources on thinking about what are the etiologies of different EKG abnormalities. And so these preparatory materials can come in all different forms, whether or not that be a textbook or an instructional video or blog articles or journal articles. And so for one of the sessions on EKG differential diagnosis, which include things like the differential diagnosis of and management of bradycardia, I assigned blog articles from common but rather good emergency medicine blogs, as well as some other journal articles for them to read ahead of time. And then the first phase of it is really about individual accountability. And so there's something called the IRAT, which is the Individual Readiness Assessment Test, which is a quiz that they take when they come to class. This is also something that can be done virtually and something that they can compete essentially within a limited period of time using testing software. I have this as a closed book, but it is graded and it does count towards a portion of their grade. And once they complete the individual readiness assessment thing, once they actually try and answer the questions themselves, then they get broken into their groups and they do what we call the group readiness assessment test, which is essentially they retake the test, but as a group, and I let them do this open book and they can debate the answers and then eventually have to come to consensus and take the quiz. In person, I have them do these scratch off cards, which can be purchased where they get a maximum number of points for getting the question right the first time, but they can get points if they get it on their second guess, which sort of keeps the groups going. So it's not just about if you get the wrong answer the first time you give up, they keep trying. What's really important here is that the groups are diverse. Students do not self-select themselves into groups of diverse abilities naturally. And so it's really important that the instructors pre-assign groups, making sure that everybody in the group has something to add to the group, and then abilities are sort of evenly distributed between the groups in this case. This can also be accomplished, virtually by actually taking the students and breaking them up into breakout rooms in something like Zoom, which is something we do within our emergency medicine residency schedule for the last, 4 months. And then finally, we actually go through the initial quiz as a group. And this allows sort of feedback and discussion about the answers between the instructor and the groups themselves, but also debate amongst the groups. Groups are allowed to make appeals. I've had very passionate appeals made by students. And the key is that if their logic is solid, they can get credit even if it wasn't the answer I chose ahead of time. And to me, that's really important because I want them to emphasize that, medicine operates in an area of gray. There always isn't exactly one answer to sort of every clinical situation. So to give an example of question for the resource assessment test, so that I've used for EKGs on electrolyte abnormalities and such, is this one. So I'll give everybody, I'll read the question, give everybody a chance to sort of answer it in their mind, which is, give this EKG. It's a 67-year-old female, presents with increased malaise, nausea and vomiting, and decreased urine output. The above ECG is obtained, and based on this ECG, you're most concerned for. I'll let you guys mentally answer that for a little bit. And then it's things. So the answer to this one was hyperkalemia, right? And then essentially we have we take the EKG, we review it as a group, we do an interpretation, and then we have a small didactic session that reinforces some of their pre-readings on what are the EKG findings of hyperkalemia, as well as discussion of hyperkalemia as the great imitator, and things like what are the most concerning findings for impending cardiac arrest, which includes things like bradycardia. So once they complete sort of their pre-class preparation, we go through this readiness assurance process, which depending on the number of questions, the number of concepts you're trying to answer, can take a while. So in general, it takes me about an hour and a half to get through all of this. And we have a 4.5 hour class. That answers really sort of what do they need to know, what is it that they need to know to apply the course concepts later. And really, in general, the overt goal is sort of cognitive, like these are the things we want you to know. But I think what's really important here is that this information also has the underlying message and a big idea that over and over through these questions they're going to understand is that EKG findings have a differential diagnosis. So things are not black and white, that medicine sort of operates within this gray zone. And you really need to be thinking about patient presentation and interpretation of EKGs. So when it comes to application of course concepts, really what it is about, what do I want them to be able to do? And I think here, a lot of my perspective is not just as an EMS educator and the medical director of a paramedic program, but also as the medical director for agencies within our region. And for so many of my students, their subsequent medical director when they join an agency. And so this is where I really work to sort of set my expectations of them as clinicians. So I could set those expectations right lower. I can say, I expect you to recognize a really obvious STEMI versus not a STEMI, or recognize and manage a basic arrhythmia. But really, I think it's important that this is where I work to set the expectations, that my expectations for them are really high, that I expect them to be clinicians who can operate in that gray zone. And for that, it's that I want them to utilize critical thinking to manage time-sensitive cardiac conditions, whether or not that be a primary cardiac condition, such as a ST elevation MI, or something that's secondary, right? So or cardiac toxic effects of overdoses or electrolyte disturbances, right? I expect them to sort of recognize and manage all of those. But there's another message that is extraordinarily important to me as a medical director to send, which is I have high expectations of you, but that doesn't mean that mistakes are not going to be made, that you're working with uncertain knowledge and mistakes are going to be made. But my ultimate expectation is not that you always get the answer right, but that you're able to work with your team, that you're able to give me a logical explanation. Appeals are always part of this process, and that you're able to learn from the experience. So just like with the pre-work, there was a message that says, you know, medicine operates in this gray area. Part of this work is also, there's an affective component to it, which is how do I expect you to sort of operate as a professional and somebody who's going to continue to learn from these experiences, even when you leave this program, right? And so in the end, it's like, I expect you to be able to take your knowledge and the clinical situation and apply that to the best of your ability. So the application of concepts part of the team-based learning is really the most important part. The application phase comes in modules, and each individual module consists of an assignment that requires them to apply higher order thinking to solve. And I think this modular format is really important because it allows the students to get really frequent and timely feedback on their decision making. It's not just they work through one giant program and get feedback at the end, but the feedback is constant. And there's really, the group assignments need to have 4 very practical characteristics to achieve the goal of higher order thinking, but also this timely feedback. And the first is that it needs to be a significant problem that they need to solve. And while outside of healthcare, sometimes it's hard to make it feel really significant to the students, I think within healthcare, we have the advantage that as long as we put this in the context of a patient diagnosis or treatment, the students usually understand it is a significant problem to their future practice as a clinician. In the case of EKGs, I think most commonly this is a treatment decision. That's usually what I go after. The next part is that they have to make a very specific choice, and that you need to force a specific choice. And that's because to make a specific choice, the students really have to critically examine the data, and it also leads to more debate amongst the students. And I tell you, there is often quite passionate debate amongst the students about the answers. There's a saying that we lead them into situations which they can only escape by thinking, and that's really the goal with each one of these modules. And then finally, the goal is that all the groups are working at the same problem at the same time, and that they have to simultaneously report their answers. And the reason is that this allows for discussion and feedback within and between the groups, and simultaneously answering forces them to commit to something, and it promotes accountability. So we all know the group discussions where everybody answers sequentially, and there's often a drift based on what the emerging majority view is, whether or not that majority view is correct. And the goal is that people have to commit to something, just like eventually they're going to have to make a commitment to a treatment decision when they're with a patient after graduation. So for simultaneous reporting in an in-person classroom, I use a very simple setup where I have colored sheets of paper with A, B, C, or D. They answer a multiple choice question that I'll give you examples of very shortly. And they basically just have to hold up their colored sheet of paper so that everybody knows what group has answered what. And it also gives me as a facilitator feedback into what they're thinking and helps me moderate the discussion. For virtual learning, it can be as simple as the different groups have to actually enter something in a chat. You can use polling software, you can use something like Kahoots, which inspires competitiveness in most students. But the key is that they have to report it simultaneously and that everybody knows like what answer did they commit to. And fundamentally, what's really important is that the instructor is really the facilitator here. And the why is almost more important than the what. It's really trying to probe what is it that they're thinking. And so essentially, what I try and do is sort of pick groups that have shown different answers and actually try and get them to say, tell me about your thinking, is a really useful phrase, because I want them to verbalize the rationale during the group discussion. So we're going to take a few examples here of specific cases that I've used. All right, so this is sort of how it works, which is they take the initial quiz, they do the group assessment, et cetera. I give them a break. It's a really long day. And then they'll get a case like this. So the family members of and they're almost all entirely real cases that I may have taken care of. So the family members of a 56-year-old female with a history of hypertension and type 2 diabetes call 911 after she passes out getting out of bed. Blood pressure is not good, 80/40, SAT is 93%, end tidal is 20, and then the palpable pulse matches the rate on the EKG. I'll give everybody sort of a second to look at. They get these as handouts or get distributed via PowerPoint. I'll give you another chance to look at the EKG in a moment. And then they get a series of questions and they work on this as a group. So my groups are 5 students and they have about 25 minutes to actually answer this. So they have a significant period of time. They usually take almost all that time, and this is all open book. So they can look up the answers using whatever resources they want to look them up. So the initial questions are lower order questions, right? There's just interpret the EKG. That's not only to give them more practice, but to actually emphasize, right, that standardized EKG interpretation is really an important step. Then they have to list a differential diagnosis for sort of the most concerning disturbance that they see in EKG, in this case, severe bradycardia. And then there's the higher order question. And this is sort of the meat of it, which is really a treatment decision. and it has to be a significant problem, which is a treatment decision, and with a very specific answer that they have to commit to. So in this case, right, they get a little bit more clinical history where the patient's lethargic, has dry mucous membranes, and poor skin turgor. The family reports several days of vomiting, and after establishing IV access, your next step is to X. And then those are essentially the 4 options that they have. I'll give this to you. I'll give you guys a minute to think about it. I'm not asking everybody to commit, but if you want to enter your thoughts in the chat, you're more than welcome to. So the groups all get that question, and then simultaneously they have to answer. And usually, you know, every once in a while, everybody will answer the same thing. But very often there's 1 or 2 groups who come up with a different answer than the others. And so at this point, right, what we have is a discussion. I share, before I even share what I think my answer is I'll ask the groups, for example, A, it says like, hey, you answered atropine, what were you thinking? All right, not what were you thinking, but tell me about your thinking, which sounds a lot less accusatory, right? And then talk to the group that answered B and talk to the group that answered D, and then have them all give a report about their logic for giving one or the other. This is often sort of where debate ensues between the different groups. And then I'll share what I think is the answer, okay? Which in this case, IV fluid bolus and contact med control for orders for sodium and bicarb. And then after I share what I think the answer is, we go through the other questions, right? And sort of put together the whole overall picture. So we'll talk about the interpretation of the EKG. And then we'll talk about what is the differential diagnosis. So for example, you know, the differential diagnosis for severe bradycardia includes things like overdose and hypothermia and inferior MI and conduction disorders and hypothyroidism and neurogenic shock, and really importantly to me, hyperkalemia. Right? And so then we go through the question itself, right? And we talk about how, right, any one of these things can actually lead to that particular EKG abnormality or clinical presentation, with the exception is that somehow we have to integrate the data from the case, right? So if I have a patient with dry mucous membranes who looks clinically dehydrated, who's been vomiting, right? Like uremia and dehydration can lead to that. And if I think about matching that, right, with the differential diagnosis of the EKG, right, which one of those things is sort of present in both is hyperkalemia. Right? And so the answer is initiate IV fluid bolus and contact medical control. So a lot of my students choose pacing in this case, right? And one of the things that we talk about is how you might choose that, right? But if it's hyperkalemia, it's probably not going to work. And so even if you chose that first, how would you reevaluate the situation to say maybe this patient is not fitting with this bradycardic ventricular escape rhythm, isn't actually fitting into the box that I've put them in, and I have to consider other components of the differential diagnosis. And a lot of these cases, and we'll go through a few, are sort of based on, I would say, my biases as not just a medical director of an agency, but as an emergency physician, and sort of things that I see as commonly missed pre-hospitally, which hyperkalemia, I think, is a super common one. So if we take another example, and Nate, if there's any questions or anything, just pause me. So if we take another example, so take this one, a 52-year-old female with type 2 diabetes and obesity presents with abdominal pain and nausea. The abdominal pain is localized to her epigastrium and started approximately 1 hour prior to arrival. It transiently improved after some Maalox, but then came back even worse, leading her to call 911. Blood pressure is 156/90, respiratory rate of 16. SAT of 94% on room air, and the palpable pulse matches the rate on the EKG. Everybody a second to look at that EKG. So the questions that they would have to work on for this module, and I remind you, they have like 20 to 25 minutes, and this is open book for them, is the lower level questions are what is the most concerning abnormality in EKG given the patient's presentation? 3 potential etiologies, so again, thinking about differential diagnosis. But then the higher level question, the one that really forces them to make a specific choice in treatment, is what is your assessment and plan for this patient? Where they have to choose, is it a probable acute MI? They call it MI alert. Is it possible? And they transport to a place where the patient could be further worked up. Do you think it's a AAA with belly pain, or is it hyperkalemia because they know that their medical director is obsessed with that, right? But they have to eventually make a specific choice. So I'll let you guys all try and make your specific choice of what you think it would be. And then I let them all, they have a moment where they all have to put up their cards or enter their answer in the chat. And then we go through the same exercise, right, where I ask them to tell me what they're thinking. And really the discussion is focused on why did I make the treatment decision that I made? What did I see in the EKG? What did I see in the patient presentation? In this case, it's a probable acute MI, and I'd expect them to make an MI alert. But we then work backwards, right? And thinking about the most concerning thing in this EKG, is this enlarged T wave, possible hyperacute T wave? What is the differential diagnosis for enlarged or hyperacute T waves, which include myocardial ischemia and hyperkalemia, but also benign early repolarization? We then take a time, there is a didactic portion, right, where we talk about the difference between the appearances, the subtle differences between the appearances of these on EKGs. We talk about the time course of EKG changes within the context of acute coronary occlusions, and then specific morphology, such as was in this EKG, like the De Winter T wave, which is a very early finding of acute LAD occlusion. But the most important thing that we talk about is we review all those things, right? But really, you know, the differences between these T wave abnormalities are subtle, and the reality is none of those things are 100%. And so the most important thing is that I take the information, I take the differential diagnosis of what I see on the EKG, and I apply it to the patient context, right, which is a woman with type 2 diabetes and obesity, or at high risk for an atypical presentation, presenting with nausea and epigastric pain, definitely a potential presentation of acute coronary syndrome, right? Like that is not a typical presentation of what I would think of as hyperkalemia or benign early repol. This is something that's really concerning for an acute MI. And especially since her pain just returned right prior to calling 911, somebody who might be very early in the process of having acute coronary occlusion, where I may not see ST elevation just yet, but I certainly would get EKGs. You know, it's going to vary by system, but one of the things I try and instill them is the confidence to call an MI when they think that there's an MI. And even if they call and they say, this is, you know, what I see, or if whatever your system requirements are for calling the MI, but I want them to be confident in their abilities and combine that, right, with the patient presentation to make the call. So here's another case. And this is the last example I have, but essentially each session is usually 4 to 5 individual modules, which usually takes up all the time. So in this case, EMS is called for a 76-year-old male with hypertension, prior CVA with confusion and altered mental status. I imagine this is probably a nursing home. On arrival, the patient is lying in bed, poorly responsive. He'll localize all extremities equally, but will only make incomprehensible sounds. The blood pressure is 68/30. The SAT is 88%. Finger stick blood sugar is 70, and the palpable pulse feels fast and thready. I want them to sort of go ahead and like picture what this patient looks like and then interpret the EKG. So they have their lower level questions, which is simply interpretation of the EKG. right? They have to think of 4, and there's more potential etiologies for the rate or rhythm disturbance, right? And then it ends with actually having to make a treatment decision, right? So they obtain further history from the patient's son, who reports that the father had not been feeling well for the past few days, came to the house to check on him, and he did not answer and found him poorly responsive in bed. He's warm to touch, the room smells of urine, and you decide to make a decision between cardioverting, administering dextrose, administering IV fluids, administering adenosine, okay? And then making that decision. Which this is a patient who is, they're almost guaranteed to see in the field. So I let them sort of make that. They have to report simultaneously, right? And the answer in this case that I give is IV access and administer IV fluids. This question always gets a lot of debate amongst the students, many of whom want to cardiovert the patient. But we talk about, they have to discuss their thinking about what they think the etiology is. We go through and actually discuss, this is AFib with RVR. And if you talk about the differential diagnosis AFib with RVR, it's not AFib most of the time. When it's AFib with RVR, it's not like, how do I treat the AFib with RVR? The question is, why are they an AFib with RVR? Right? And so we focus on all the different things, right, that can present with this particular disturbance, right? And think about, how do I put that together in the clinical context of a patient who clinically looks septic, right? So if I think about the why that a patient is an AFib with RVR and a clinical presentation that looks like sepsis, I have to assume that this is likely sepsis, and probably, right, administering IV fluids is an initial step. Not saying that this patient is never going to be cardioverted, right? But that's usually not going to be the first step in this patient. So then we have a discussion, right, talking about sort of what are the underlying medical illnesses and their presentations, and understanding that a fair proportion of patients with sepsis and a fair proportion of patients with AVR, a fair proportion of patients with sepsis will have AFib with RVR, especially if they have underlying AFib, because that's just tachycardia, right? But that a fair proportion of patients with sepsis will actually present with AFib with RVR. So those are just examples of sort of 3 specific questions that I've used in these activities with my students. But really, if you're making your own activities, the checklist for the group activity is that, you know, when they're working, comes in, whether or not it's a good activity is prior to the group discussion, right? When they're working on these individual things, which are like really 20 to 25 minutes of group time during the module, is, are they working on the same assignment? Are they going to be required to really make a specific choice? And so not every component of my questions is about making a specific choice, but at the end, the thing that they have to commit to is a specific treatment decision. Just like in the field, right? There's lots of things that you can consider, but in the end, they have to make a decision about whether or not they are or are not going to do something, or which path they're going to take. Within the group discussions, right, the question is, do they really need to come up with a consensus? And as much as I'm not a huge fan of multiple choice questions, these types of multiple choice questions actually force them to come to a consensus, which leads to sort of a lot of debate within the groups. But the goal is that the focus of that discussion is on the why are we picking this particular choice, right? What are the risks and benefits? What is the underlying pathophysiology that's leading me to make this particular treatment decision? Okay? And the goal is that when they make that specific choice, that we're able to sort of compare directly between the groups of what different groups are coming up with, so that we can probe their thinking on their treatment decisions more. And so for between groups, right, we really want things simultaneously reported. And we want the group reports to focus attention on the key issues, which is that tell me about your thinking question, right? How did you choose one treatment decision versus another? What was your underlying logic? Right? And really, the goal is at the end of this, when you look around in your classroom, or if you peek into the different, breakout rooms via Zoom, are they really debating? Are they testing their knowledge? Are they combining, integrating their data and really thinking about how they're going to overlap those two and really apply that to taking care of patients. So I started this webinar before I lost you guys for a little bit there by asserting that I think paramedic education is really one of the greatest challenges in medical education. And I tell my colleagues, I participate in emergency medicine training as well, and I tell my colleagues that all the time, right? As I have a very fixed period of time with my paramedic students to prepare them to do an incredibly difficult job. With sort of less resources than I ever have as an emergency physician in the hospital. And I think over the last year, this challenging job has gotten even more challenging as we've all sort of been distributed into this virtual and remote environment. But regardless of the environment that we're doing it, right, we still have to get to this common end goal of building clinicians who can really think critically about sort of what is the right thing to do to the patient, and then see that medicine is not, there are very rare sort of black and white yes no answers in medicine. And so, you know, team-based learning is just one method to do this that I really like, and I would say that a lot of the lessons that they learn there definitely have to be reinforced elsewhere. So very often we'll go through this, but some of these concepts reappear in oral board scenarios and simulation scenarios later on in the year to reinforce them. They also reappear clinically. So some of those patients, right, are things that they're gonna see in real life in their field clinicals. But I think that this is doable, albeit with somewhat of a learning curve in a virtual environment. I will find out next year, as I can't have all my class together in the same room for the foreseeable future. But I think that the big challenge of our current, it was a huge challenge before, but a bigger challenge now is sort of how do we make sure that we're teaching this knowledge application when we're not all together in the same place. So I want to end by sort of thanking several people and then sharing some resources. This is, I think, a really useful book, Team-Based Learning for Health Professions Education, that really goes into the details of how do you actually build team-based learning modules. I use this for several other things, not just EKGs, other things like talks within the paramedic program. I'd like to thank Rebecca Babalek. She's my associate program director in residency, who really opened my eyes to all the ways that team-based learning can be used, including the teaching of EKG differential diagnosis and application for cardiology. And then Bill Camella is the program director and lead instructor for the MCC paramedic program, and Kate O'Donnell, their clinical coordinator, is the clinical coordinator and lab director. And they're definitely my partners in crime in this journey to make clinicians. So I just definitely want to thank them, because they sort of all of us work together to nail down these concepts for our students. And that is all I have.
Thank you, Dr. Dorsett. I really appreciate all that, and we definitely got some very valuable information throughout that whole presentation. We have been having some very positive feedback being submitted through the chat and the Q&A, so I want to thank everybody who's been submitting, and please continue to submit any questions and comments that you have. If you may be holding anything back, please go ahead and share with us. So far, we have had several people interested in sharing this with other faculty and other colleagues that they're working with. Do you have any problems with us sharing this afterwards? It is being recorded, and we intend to put this on our YouTube.
Oh, of course not. And let me just stop the share, and I can actually turn on my video. Yes. Hold on. There we go. Can you see me? So I am more than welcome to share this, and I can actually, I wonder if in my chat I can actually just put my email, and I'm more than welcome. I'd be happy to actually share all my modules and my quizzes and everything with anybody who wants. So,
And go ahead and include that in our follow-up email and everything that goes out to everybody who attended today's presentation. I see we have somebody with their hand raised. If you had something to say, please go ahead and just submit it into the chat. And we have a few minutes that we can address any of these comments?
Sorry for the snafu at the beginning.
Not a problem at all. We all certainly been dealing with some technical difficulties throughout this whole thing, but that could actually be something, if you wouldn't mind speaking to that. Have you noticed any things that have worked and that haven't worked while transitioning these learning modules that you have to the virtual classroom? Are breakout rooms and everything working out very well for you doing this?
So I haven't done breakout rooms with my paramedics, but I have done them with emergency medicine things, and the breakout rooms are actually working quite well there, and it's pretty easy to go from the larger classroom for discussion and then take the breakout rooms, which make it a lot easier for the individuals. For larger groups to discussion, you sort of have to designate one person for the group, so you lose some of the dynamics there. But and I think the hard thing is when people are in breakout rooms, they're not communicating with the instructor simultaneously who can answer questions. So I think instructor-wise, it may actually be more, you might actually need more instructors, or at least, utilization of lab instructors to sort of go into the different breakout rooms and facilitate. But from the point of like residency education, those actually have worked well. So do you have any ideas for team-based learning for asynchronous classes? So I think the hard part about, I think you could use some of those same modules. The problem is that if the entire class is asynchronous, then you sort of lose that simultaneous reporting component. And what I found is in class, that simultaneous, like the moment where you're just like 1, 2, 3, everybody like enter your answer. There's certain stakes and motivation and excitement that the students have about that, because people tend to be sort of naturally competitive in this way. So you lose some of that and that simultaneous group discussion. But I think that you could use a lot of the same kinds of modules that really sort of force them to think about the basic management and has that specific answer that they really need, and have them work as small groups to come up for those things. And then ideally, they could actually work through some of those modules separately, and then you have them come together and simultaneously report and have a group discussion. Because the group discussion is really powerful, where people are saying, so for example, with that AFib case, right? A lot of the students want to cardiovert that person because they're hypotensive and they're in AFib, and they're like, well, if that's the etiology, then I want to treat that in a time critical way, and I don't know if fluids are going to work. And then we have a big debate about sort of the risk and benefits and what's the difference in the what if you had to give sedation versus not give sedation, and where are the potential harms of sedating a patient who's already hypotensive and such. And those discussions, I think, are really productive and help the higher order learning. So it's hard to do some of that asynchronously. So how to include working paramedics in these kinds of models? I haven't, so do you mean working paramedics to actually have them to do this as a continuing education component and working paramedics, or get some of our working paramedics into the classroom to debate this? I use this at my EMS agency occasionally as well, when I do like quarterly trainings. So you can use the same kind of model for that. I haven't tried doing anything where I sort of integrate sort of practicing paramedics in our systems into this. In consideration for online deliveries, have you used online TRAT score sheets versus the scratch off? I have not. I think that is something that I could definitely look into. I'm going to take notes. I'm learning here. So I have not used those. Essentially I've only used essentially like Kahoots, because the Kahoots has, like this, you get more points for answering more quickly and things like that. And there's like a little bit of competitiveness into it that really gets the students into it.